The paradigm has shifted away from just doing filler Botox and pushing people off into their 50s because often there were some downsides of it.
What's the difference between Botox and filler? Because some people use the terminology interchangeably when really they're very different.
You basically treat Botox all over the face, to be honest with you. A lot of people are dabbling into Botox in the jaw and neck area as well because you can get a little bit of pulling effect from it.
There has been the notable twin study where they had two identical twins and they compared one who had Botox therapy or neuromodulator for years and the other one who did not. And there was noticeable differences. And that study became a Hallmark article. I mean, people watching this podcast can look it up. It's available.
And it depends on the character of the face and the character of the person, right? What they want and how they want to look. We take all that into consideration.
I think brows in particular. In a man, if you end up with a Spocky eyebrow, it's sort of a giveaway that they've had toxin.
Like Spock?
It happens all the time. And
did Spock have Spock? Was there Botox around then?
No. Hi guys, it's Dr. Solomon. I want to welcome you back to our podcast, Unfiltered. Today we have one of our very own nurse injectors, Nurse Vesta, who many of you may have seen in our clinic. And Vesta's been working at our clinic for many years. She has expertise in all sorts of things in facial plastic surgery. She was involved in our surgical center, preoperative care, postoperative care, is a nurse injector, has a lot of experience with Botox, filler, biostimulation products, as well as energy devices, Morpheus and Pico. She also has become a nurse educator. She works within the industry, educating other nurses on many of these things that we're discussing today. So we thought it would be great to bring her on today to discuss how we work collaboratively at my clinic, some of her techniques and how she likes to incorporate the stuff that she does with the surgical stuff that I do. So I'm going to let Nancy introduce her, and Nancy's going to ask some questions that'll lead us into some conversation.
Hi, everyone. Well, I think you gave her a great introduction.
Well, thank you for that. Yes, that was so good.
So we're going to talk today about Botox. Botox is one of the most common, well-known aesthetic treatments, and it's often the first treatment that people dabble in when they start noticing changes to their face, or even young people who want to do preventative treatments. So we are going to start off with the most basic question for those who are just tuning in for the first time or may not know much about Botox. I just want to also mention Botox is a brand name. It's like Kleenex to tissue. So Botox is actually a brand name for a neuromodulator, which relaxes muscles. And there's other brands that do the same thing, but we're going to refer to Botox or other brand names, but it's a neuromodulator. Okay, so Vesta, what is it? What is a neuromodulator? What is Botox? What is Dysport?
So it's basically something that inhibits muscle contraction. So in tune, it kind of helps out with fine lines and the wrinkles that people most commonly are bothered by. So people usually will inject areas such as like your glabellar complex or what people call the 11th. People will want to inject the forehead, crow's feet, but there's a lot of other areas that you can actually inject with a neuromodulator, and we can get into that.
So what's the difference between Botox and filler? Because some people use the terminology interchangeably when really they're very different.
So filler, as the way it sounds, it's filling. You're basically creating volume in an area that has a little bit of deficit, and you're adding and augmenting, right? Where a neuromodulator such as Dysport, Botox, or Xeomin is basically stopping your muscle contraction. So it's more for wrinkles and fine lines.
Okay, so back to what you were saying prior to that. So Botox treats, we're going to go over the face, the crow's feet right around here.
Yep.
The
glabellar complex. Yep, the 11th.
Yeah, we're using layman's term for those who may not know all the terminology. The forehead wrinkles.
Yeah.
Where else can we treat? Lip lines around the mouth.
Mm-hmm. So your smoker's lines.
Smoker's lines.
You could basically treat Botox all over the face, to be honest with you. A lot of people are dabbling into Botox in the jaw and neck area as well because you can get a little bit of pulling effect from it. A lot of people will use it for a gummy smile. A lot of people will use it for kind of the little bunny lines that you get when you're smiling, although I think it's cute and I don't really like treating my patients for it because it adds character. So another area that people inject Botox is the masseters. So people use it for TMJ and also a jaw slimming effect as well.
So Botox, aside from functional, it can also give an aesthetic appearance.
Absolutely.
So I've seen young girls come in the office and they say, oh, I'd love like a brow lift. Or they say, I want a lip flip. Instead of filler, they want a fuller upper lip. Or they say they want like a jaw slimming effect.
Yeah.
Right. So you can do it for, I mean, it's an anti-aging, plus it's also like a facial enhancement, facial sort of character reshaping on the face.
Absolutely. And we have to be careful because a lot of times patients come in, and I'm going to let Dr. Solomon speak about this as well. They'll come in expecting kind of facelift results with Botox or Dysport or whatever we may be using. They'll want a subtle brow lift, or some will want an extreme brow lift, but you have to take into account the anatomy of the patient's face, the age demographic, their facial anatomy, and it's something that cannot always be done with just Botox. They have to consider brow lift, right? It's the position of their brow or the age, right? So I don't know if you want to talk about that when patients kind of come in expecting, I don't know, drastic results from Botox for a brow lift, but it's something that can't exactly be achieved.
Yeah, so Botox and filler are great add-ons to surgical practice, and there's sort of a period in time where they alone can be adequate. So you could be using Botox filler, some skin care, and the patients in their 30s, for instance, will be very satisfied with the skin maintenance, preventative aspect of the products, and possibly some facial reshaping or volumization. And similarly, into early 40s, that can sort of be all that's required. But then there's a point in time where surgical intervention is required. Usually when there's a significant amount of descent of the upper third of the face, and whether the cheeks have fallen significantly or whether the jawline has become less defined and there's become increased laxity of the skin, leading to some crowding and changes along the neck. Earliest signs are often a little bit of a jowl or some banding in the neck. And so the paradigm has shifted away from just doing filler Botox and pushing people off into their 50s, because often there were some downsides of it. People started getting pillow faces or overfilled looks, and it almost gave filler and Botox were lumped together and giving them sort of a bad rap. And they're great products, but if they're used as their only tool in the toolbox, you're going to create funny features and overfilled faces. So we saw that in Hollywood and all sorts of like pop culture stuff, and there was a big sort of pendular shift saying, oh, stay away from those things. It's not that you need to stay away from it. You just need to not overdo it and then incorporate surgery when a patient requires surgery. So the procedures themselves, it's a bit of a continuum. So for instance, you can use surgery and you still could be getting Botox while you're getting surgical treatment. You can get surgery and you can enhance your results with some filler product after the surgery. So you asked about brow lift in particular. Some of the patients are getting, in younger age demographics, are getting brow lifts because the brow lift that's achieved with the Botox may not be quite what they're hoping for, which possibly could be surgical in nature. So a foxy eye or a lateral canthal tilt or shortening of the distance from the hairline to the brow and modifying that for patients who have relatively low set brows. Often an endoscopic brow lift will give a more permanent and in fact, a better looking result. The downside of Botox for trying to achieve that is often patients look almost spocked and overdone because it's hard to sometimes control the brow position. It's hard surgically as well, but I think it's hard in some patients' anatomy. And over time, we see people with their brows who've been doing tons of Botox. I've talked about this in the past on a podcast where their central brow almost descends too much because a lot of Botox is done centrally, and that can knock out the corrugator muscles, which is the ones that produces the 11s, but it also may drift up to the frontalis muscle, which is what elevates your brow. And if you're doing it consistently every 3 months for years and years, your frontalis atrophies and your medial brow actually falls lower than it naturally was placed, creating almost a surgical problem where you need an open brow lift or an endoscopic brow lift to try to lift those medial brows back over the bony rim. So again, Botox is great, but it's got to be done by an expert injector. And all these things need to be considered when you're doing it long-term.
And that's why I was just going to add why I was so lucky to work with you in surgery, because you're able to kind of see the anatomy inside out, and I'm able to kind of gauge and just let the patient know whether something is attainable with Botox or whether it's the surgical route or using both, right? So being able to say no or being able to tell the patient that they aren't going to get the results that they are necessarily expecting is really important, right?
That leads me to my next conversation point that I actually wanted to mention, because you can walk down the street and you can find a clinic probably on every other corner that treats with Botox. So the nice thing when you come to our clinic is that we do the full gamut. We do everything from the basic Botox treatment and then up the ladder all the way to surgery. So you do know that if you're seeing one of our providers, you have options. The option isn't just Botox because that's what we sell, or Botox and filler because that's what we sell. We do everything. So you're going to get a very honest and candid consultation and critique of what would be the best treatment for you. So if we think, okay, you've done enough Botox, or really Botox has dropped your brows, or if we think, and dosing as well, like we also know our dosing to make sure that, you're getting the appropriate amount of treatment so you don't get that frozen forehead look that people shy away from. So anyways.
So you raise a good point. Botox, when I started, was available at dermatology offices, surgeons, plastic surgeons, facial plastic surgeons' office, but it was really done by a limited number of care providers. Now there's Botox available at Medi-Spas throughout, in Toronto, all over the GTA. And it's not that there's bad injectors in one or the other place. There's some great nurse injectors that are working in Medi-Spas. I can't take that away from them. But at our clinic, we try to provide a intake with the patients where we're doing medical photography, we're assessing the patient for surgical and non-surgical needs. We're also offering assessment for possible candidacy for laser resurfacing. So all of your beauty needs are going to be assessed when you're coming in. Then we're going to be doing the treatment, and then we're going to be monitoring your response to therapy as part of their medical file, medical records. It'll be available. We'll keep their medical records for years to come. So I don't know. From my perspective, I think there's some advantages. I don't like thinking of Botox as just sort of almost like any other beauty treatment, like getting your hair done. It's a medical procedure, and we like to keep all the medical files, have everything on site, have an integrated approach to the patient so that we can offer them surgical, non-surgical, laser, and treat them like any other patient, whether it's Botox or a facelift. They're all our patients that we're taking their medical care as of utmost importance.
Let's talk about when to start treating with Botox. Is it better to start when somebody's in their 20s, 30s? They want to do it as a preventative before they start getting the wrinkles? Do we wait till we get the wrinkles and then reverse our tracks? What's the right answer?
I don't know if anyone has a direct right answer, but there has been the notable twin study where they had two identical twins, and they compared one who had Botox therapy or neuromodulator for years and the other one who did not. And there was noticeable differences. And that study became a Hallmark article. I mean, people watching this podcast can look it up. It's available. But what it really highlighted was the preventative aspect of neuromodulators, in that by doing it on a regular basis, it's going to prevent some of the lines forming in your skin. So I think younger is probably better. Low dosing at a younger age. The dosing may change over time. Again, our medical records, we would document over time. We can look back on patients we did 20 years ago in our clinic and look at their dosing. We still have it available to what they're requiring now. Interestingly, some people's dosing actually, as they get a bit older, need a bit more. And then it almost tapers off that they're doing regular Botox and they start to need less and less because there's probably some muscle atrophy occurring as a result of the regular nature of the treatments. I don't know, Vesta, what do you think?
I was going to say the same thing, somewhere in the middle. You don't want to start too late when you already have those lines forming, because I'll get a lot of clients that will come in and they'll say, I want to get rid of these lines. And they've had those lines maybe for over 20, 30 years, and they think one dose of Botox, one session is going to get rid of it. But in fact, those patients aren't going to necessarily have those totally gone. It might improve it. It might take away a little bit of the edge of it looking so sharp. But those, once you have those, we call it static lines, it's very, very hard to get rid of them. And it's something then you have to dive into the laser world to kind of refine it a little bit more.
That makes me think of men versus women, because sometimes a man maybe in their 50s could have those static lines that you're referring to. So how do you treat a man versus a woman, let's say in their 50s? Do you treat them the same? Do you give them the same dosing? Because I would say probably, and tell me if I'm wrong, a lot of men or there's not as many men doing Botox as women. So in order to make men understand that it's open to them and that they won't look strange or funny or frozen, what does dosing look like?
So it's a little bit tricky, but the dosage for men is generally a lot higher than women, but you have to just be a little bit careful to not over paralyze, in my opinion, men, because I think they look a little bit weird when they're totally frozen. Whereas a woman, it looks a little bit nicer when they have that frozen look as to oppose a man. It just looks very unnatural. And you tell me as a man what you think about that, but it's somewhere in the middle where you still want to have a little bit of animation while not looking so harsh and mad all the time, right?
I like lines on a man's face, to be honest. We just had a facelift patient in today, and he looked fantastic. I mean, his neck, his jawline was great, but I wouldn't want to see him do too much on his forehead. He does have some of those static lines, but I thought he looked so good. He looked the way he should look. He looked like the best version of himself at his age, and then the facelift did the work, I think.
And that's going back to like the multiple modalities, right? Like, I don't think Botox is just one fix. Like if a man comes in the 50s and has those deep set static lines, you'll want to use laser, you want to do surgery, good skincare, Botox, fillers, all of that in conjunction. I don't think is just one thing that's going to make the person look 10 years younger.
And it depends on the character of the face and the character of the person, right? What they want and how they want to look. We take all that into consideration.
I think brows in particular, in a man, if you end up with a Spocky eyebrow, it's sort of a giveaway that they've had toxin
Spock,
which they look very.
It happens all the time. And
did Spock have Spock? Was there Botox around then?
No, but I think in men, for me, the brows the sort of giveaway for men. So when I do toxin on men, I'm usually very cognizant to make sure that I'm trying to avoid a Spock or a pull. So I'll stick with specific dosing that I think works on the patient to avoid those types of looks. There's also a misnomer though. I think some patients say I want less Botox, not more Botox, in order to look more natural. But the truth is the opposite. Many patients underdose themselves, and if you think of the face as a dynamic structure with lots of different muscles pulling in different directions, and you neutralize one set of muscles because you're doing a low dose and the patient is nervous to do maybe what we call recommended dosing, they may end up with a bit of a pull. So for instance, they do too little on their brow and now they've done just their central brow, but their lateral brow still hyperdynamic. And then they're pulling on the lateral brow and their eyebrows are getting distorted. Whereas if they actually done a couple more units laterally across their entire brow, which is a higher dose, they may have not had that problem. They would have looked actually just more refreshed with the entire muscles just a little weaker than parts of the muscle being paralyzed completely. So many patients will say, I just want to do the glabella. That's one area you kind of can treat in isolation. But even when I treat the glabella, I like to do the crow's and glabella together because they're both kind of depressor muscles and it usually just will relax everything. If I was going to leave out just one area on a man, I may leave the brow untreated and treat just the crow's and the glabella. But frequently we'll do crow's, glabella, brow, but low dosing on the brow across the upper forehead and preserving movement from the upper brow to the eyebrows themselves. And that's the other common thing that we get as patients come in, we do their treatment and they love the result, but they want more. The opposite will happen and they'll come in and
touch-ups. We're talking touch-ups.
Yeah, we need to get into that.
We'll call it toxin touch-ups. So why do toxin touch-ups happen? One is it can happen because, we're doing a treatment, we're waiting, and we have to wait about a week or so to see the response. So we bring people back anticipating it's for months that they're going to have those results. We want to treat them.
Let's talk how long.
Usually we want to treat them within 2 weeks, a touch-up, because we don't want to start adding touch-ups weeks down the road because then they're going to have toxin working at different time periods.
Can I just say it a little
3 to 4 months
decisively?
It should work.
So Botox works for 3 to 4 months.
3 to 4 months, but it takes about 3 to 10 days to kick in, depending on which product you use. So at about 10 days, we typically want to see patients back, especially if it's the first time they're treated in our clinic, so we can assess the results of what we did. Then we'll determine, was this dose appropriate? Did they need more, or did we inadvertently do too much? Then we'll make notes. Then we arrive at what we think is the optimum dose, and then we're going to try to duplicate that optimum dose. So the first time you come to our clinic and maybe playing around with a little bit of dosing until we figure out the optimum dose, and then hopefully we have that dose figured out for you for a long time, making slight tweaks as necessary as you go through the aging process. But again, with touch-ups in particular, some people want to touch up just above the eyebrow. There's still a little bit of movement above their eyebrow. And we often leave that functioning on purpose to prevent the brow falling completely. I tell people it's like a curtain, and if you basically let the whole curtain down, everything's going to come down. So you'll end up with a super smooth forehead, but your eyebrows will be heavier. And we see female patients noticing it more because they'll notice crowding around their eyelids. So occasionally we'll see patients for blepharoplasty or brow lifting, and we'll say, when's the last Botox you did? And they'll say, oh, I do tons of Botox. I look how smooth I look. And I'll say, come back when your Botox wears off because I want to reevaluate you once you have some muscle movement, because sometimes they come back and it's a very different sort of assessment.
Going back to the touch-ups, when you have clients that come in, let's just say a month and a half after their initial treatment, and they're like, I'm here for my touch-up. Well, your Botox has already started working for the month and a half. And when you just keep adding and adding and adding, it just becomes a mess where your patient's going to have to end up coming almost every month to get to that attainable result that they wanted from the start. And it's not ideal.
So the message is it's really important to have a dosing or figure out the dosing. And then from that point onwards, stick to that dosing or within a few units, and then come see your provider day 10 to 14, just to make sure you're the appropriate dosing. And then you have to sit with it and leave it until your next cycle starts, which is about 3 or 4 months away.
4 months generally.
That's pretty much the routine with Botox.
You should probably mention complications, because like anything else, while 90-something% of it's great and people love toxin, it's probably universally one of the most favorite anti-aging therapies that's been introduced into the market for the last 20 years or more. But there are the odd person who gets a complication. The worst complication from toxin that we see would be potentially asymmetric smiles if the toxin's done on the lower face, which is transient.
It's affecting muscle. So muscle one can be weaker than the other, and then you can kind of look like that. And
eyelid ptosis can occur. And eyelid ptosis, certain patients are really, it can be technique, but certain patients have anatomy that are a little bit of a sitting duck for it. The commonest cause of ptosis would be not just the toxin alone, but likely the patient had some pre-existing what's called levator dehiscence, or elongation of what their tarsal plate on their upper eyelid, meaning that there's a bit of a genetic elongation of their eyelid, and the muscle there is already weak, and then the toxin drifts into that area, and they can end up with ptosis. Or badly placed toxin can cause ptosis. And there are some treatments for it. If you are unfortunate enough to develop an eyelid ptosis, then there's some eye drops you would have to use temporarily until it resolved. So occasionally
will it resolve within a few days?
No, patients, it can last a month or two, sometimes even longer. So obviously it's something that should be best avoided. And there are certain techniques, our staff are well versed in it, to avoid it if at all possible, but it still can occur. Every clinic probably has seen 1 or 2 ptosis patients over, I wouldn't say it occurs often, but I'd say we see it in our clinic maybe once a year type of thing. And we're treating hundreds of people, so it's rare. It's obviously upsetting when it happens, but the eye drops do help a lot. So that's the commonest. We have the odd person who's overtoxed their forehead and they come in with heavy brows. They're not happy that you have to just wait for it to wear off. And lower face asymmetries can occur, but they're rare.
And that goes into like the aftercare of having Botox done as well. Like if we give our clients really strict instructions not to lie down, not to do exercise, not to go into hot tubs, pools, jacuzzis, like all of that stuff. So certain things, if clients aren't following post-care correctly as well, that could attribute to some of the causes that you were talking about.
And lastly, I was going to just mention Botox fatigue. Is there such thing as people getting their bodies sort of start rejecting, whether it's Botox or Dysport, whichever brand it is that they're using, that they get fatigued?
The word fatigue, I guess, is colloquial, in the sense that it, like conversationally, yes, it can fatigue or not works. And we see the odd person who says Botox worked and then stopped working. Right. The assumption medically is that they've developed some antibodies to it and therefore may require higher dosing, or it just becomes something that's less effective for them. There is another product, I'm not even sure if it's in Canada, Daxify, which is slightly different, which is to last even longer. So we occasionally see patients flipping between the products, between Dysport, Botox, even, and maybe Daxify in the States. If they find that they're becoming non-responders, likely to develop antibodies, not so much specifically to the toxin or active ingredient, but some of each of these products is slightly different in how much protein they have around them on a molecular level. So maybe they have an antibody that's mopping up the active ingredient because there's an antibody to a given protein. So sometimes switching between the products can help, but it's pretty rare, but we have seen it at our clinic.
Would you say that when clients come in and are doing the constant touch-ups on a monthly basis, would you say in your practice that you've seen that it's helped develop the patient create those antibodies and it not working as well?
I don't feel like I have that many patients who are non-responders. It's usually someone that's coming that's been to like 5 different clinics and saying they want to see if we can do anything different, or they're patients that have come here. Part of their medical intake is that they're non-responders to toxin. Yep. They've tried everything and they want to get a brow lift because they feel like it's not working anymore. So they become surgical patients. So,
and the beauty is there's a lot of products out there that we could use on a patient to get it to work again, right?
And proper dilution.
Ooh, yes.
Yeah, so Nancy, touching on dilution, whenever you get a product that's coming in, it's going to be kept in a refrigerated environment. We take the temperatures of our fridge every day to make sure that it's at the appropriate recommended temperature. Then there's dilution. We're using sterile saline from a pharmacy that's being mixed with the toxin to make it into a liquid form from a powdered form. So there is something to all these things. These things may vary clinic to clinic, dilution of how much saline they mix it with. So, you never know like exactly what you're getting at. Each clinic may do it slightly different. Some people like to dilute it more than others. We've sort of been doing a standard dilution that's probably used in most clinics North America wide and works for us. So anyways, I feel like we've talked a lot about toxin, more than I thought we'd be able to. I thought it was going to be a boring topic, but
I told him not a chance.
Well, whatever.
Not a chance.
There's a lot to talk about. I mean, toxin
Tell us how you really feel.
Toxin's a medication, and Health Canada doesn't like us necessarily talking too openly about medication, but I think we've sort of explained clearly
and it is a
here.
medication. That's what everybody also needs to understand.
Yeah, it's a medication. Yeah. It's a pharmaceutical medication, and they have their own governing rules on it. It's dispensed and sold to medical facilities. There needs to be a medical director or a nurse practitioner involved in its acquisition, its care, how we hold it in our clinics in a refrigerated environment, how it's diluted, how it's delivered. So even though it seems like a trivial matter, it's still a medication. While we have Vesta here today, I want to take the opportunity to ask her a couple of questions about energy devices. Vesta's been working with us for many years, and she's made a big part of her expertise working with energy devices, specifically microneedling radiofrequency devices. And there's a number of types of machines that she's utilized, from Potenza is one of them to Morpheus is another, but we're going to talk generically about microneedling radiofrequency and another device known as Pico laser, which is a name of an actual device, but it's also a name of a wavelength of a laser. So Vesta, I just want to ask you briefly, tell us why Pico is unique, what is it used for, and how do you use it in our practice?
So the Pico is a 755 nanometer. That's the wavelength that we use. Why it's called a Pico Sure laser, it's because it uses a picosecond. So you're using 1/1,000,000th of a second for having a photoacoustic effect on the skin to make your pigmentation kind of disappear.
Unlike lasers in general, which burn away tissue, this one's actually using a photoacoustic, which is something from an engineering or physics point of view. Just explain that to laymen. It's actually, I believe, shattering the pigment.
It's basically shattering, or you want to say vibrating the pigment, and it uses your body's process of drainage through your lymphatic drainage system to get rid of the pigment. And that's why your treatment sessions are generally 4 weeks apart, because your body is actually helping you get rid of the pigment.
Okay, and how do you use it? Like, who do you do it on?
We can use it on all skin types, and that's what's really nice, because in this industry, we have all these lasers for people who have lighter skin complexions, but not really anyone who's Fitzpatrick, maybe 5'6", who have a little bit of a darker skin complexion. And I mean, they still have needs, they still have acne scars, they still want lasers done as well, right? So that's why Dr. Solomon decided to get this laser, because our clinic, we see all types of ethnicities come in, and we want to make sure we are addressing everyone, and everyone feels included, and everyone is able to have something done. So this unique laser, we're able to use it for so many things. So we can use it for acne scars. We could use it basically for sun damage, melasma, hyperpigmentation, scar after surgery, which is what I like using with your patients as well. And overall skin revitalization and skin rejuvenation for people who come in and just want a little bit of a oomph for their skin, right? It kind of gives that little boost that everyone wants.
And it's the same laser that can be used for certain tattoos, right?
Yes. So another great aspect of the Pico is for tattoo removal. So those pesky tattoos that people have had for years and years and years, they want to get rid of them. And there's a lot of other tattoo devices out there like Q-switch lasers, which take almost double the amount of time to get rid of tattoos. But the beauty of the Pico is you can get rid of the tattoo in less than half the amount of time, which basically means you spend less money and a lot less time trying to get rid of your tattoo.
Hopefully you found this informative. It's a super common thing. Probably most of the listeners have tried it at some point. And if you want to come see us for it, we've got great care providers and happy to see you. Thanks for listening to another podcast of Unfiltered, and we'll see you back soon.